Hi, this is the third and final video presentation about arbovirus. Here we will be mainly focusing on yellow fever, dengue and Cassandra forest disease, which comes under this family Flaviviridae. So let's just to begin with, I'll repeat the characteristic features of arbovirus. Arbovirus are arthropod-borne vector diseases which can be transmitted with the help of a vector. Usually Culex or Aedes aegypticus are the common agents which are transmitting the infection from the patient to the healthy individual. And there are many family members are involved in the superfamily of Arboviridae, which are Togaviridae, Flavi, Bunia, Rio, Rhabdo, Arena and Filoviridae. So among those, we completed about Togaviridae, which included chikungunya virus and equine encephalitis virus. Now the second and the most common one will be the Flaviviridae, and which includes the genus Flavivirus, and which are of two different types, one which can cause febrile paroxysm and one which can cause encephalitis kind of condition. So among those, dengue, Japanese bee encephalitis, Cassandra forest disease and yellow fever disease are the commonest among all other viral arboviral family members causing complications in Indian subcontinent. And among the list, we completed Japanese bee encephalitis, and in this presentation we will be mainly focusing on yellow fever, KFD and the most important, most significant dengue viral disease. All these viruses are spherical in nature, right? In terms of the shape, they are spherical in shape, and their size is around 60 nanometer, and they consist of a single stranded RNA as a genome, and they are enveloped virus. That means they can extract some amount of the host cell membrane at the time of budding. When they comes out from the host cell body, they takes up some amount of host cell membrane and becomes enveloped. And they also got some surface receptors, surface spikes, which can make them specific to the target cells and specific to the target site where they can reach and can multiply, there causing further complications. So let's begin with yellow fever. So yellow fever is an acute febrile condition, and the severe case which is usually characterized by liver dysfunction. So that's the reason why we have kept the term yellow fever. So there will be, of course, jaundice kind of condition in those individuals with severe cases of yellow fever condition. That's an acute febrile condition or illness initially, but in extreme cases it can spread to the liver. It can cause liver dysfunctions over there, which will lead to jaundice, renal dysfunction, and there will be hemorrhages with and this has got high rate of mortality. So in the earlier cases, in the early stage, the infection can be limited with acute febrile illness, but if it goes beyond our hand, it can develop or can reach up to the liver, causing liver dysfunction, and will lead to the death of the individual. It is commonly seen in South African countries and also in the Central and South American region, and it is transmitted through an agent or a vector known as Aedes aegypticus, or which is also known as tiger mosquito because of their size and the specific biting habit. And this is something which is helping in the transmission of yellow fever. These are the vectors which are involved in the transmission of the virus from patient to another healthy individual. And a little bit about the history of yellow fever. It was first isolated in 1927 by inoculating monkeys with the blood of African patient as CB. So he was the first known patient of yellow fever, reported case of yellow fever, and from his body we have successfully inoculated or transferred this virus to monkey kidney cells, monkey blood, right? And we successfully isolated the virus from them. And if you see the transmission cycle or epidemiology of this particular viral infection, yellow fever, it includes two different type of cycle. One is called the jungle cycle. In jungle cycle, the infection actually happens between monkeys and the forest mosquitoes. So forest mosquitoes will transfer the infection among the monkeys. So only monkeys and forest mosquitoes are involved in the cycle. That is called jungle cycle. And when you talk about urban cycle, the interaction or the transmission actually happens between human and urban mosquitoes. And if you see the incubation period, the incubation period in mosquitoes is within 8 to 10 days. The virus matures and the virus is ready for the next round of infection cycle within 10 days in mosquitoes, and in human body within 3 to 4 days, the person will start showing symptoms. So the forest cycle is also called sylvatic or jungle cycle. Here the reservoirs are monkeys, and again the common agents which are transmitting the infections are mosquitoes. Right. Now, talking about the clinical manifestation, it usually starts with the mild symptoms like fever, chills, headache, dizziness, myalgia, and backache. That's a common clinical presentation, followed by nausea and vomiting. The person will also experience high temperature and low pulse rate. There will be jaundice, albuminuria, and bleeding tendencies, and death will occur due to the hepatic or renal failure. That's the most serious case. It can develop into hemorrhagic manifestations, platelet dysfunctions, and liver involvement with zonal necrosis. Zonal necrosis means one particular areas of liver will be undergoing severe necrosis, and this is typically because of hyperactive immune responses which are initiated against the viral infected cells. Now, the most significant clinical presentation, or which has some diagnostic value, is the formation of Councilman bodies, which are formed as a necrosed mass of cells within the liver, which is hyalinase, which is rich in hyalin and eosinophil. So, which is hyalinase and eosinophilic masses of bodies which are produced in liver, followed by the fatty degeneration and necrosis, are known as Councilman bodies. Now, they are the apoptotic bodies, or that means they are self-destroying bodies which has generated their cell death, and that is the cell-dying bodies. They are known as Councilman bodies. And if you identify these kind of bodies, Councilman structures or cytopathic effects in affected individual biopsies, definitely you can suspect a serious case. So, Councilman hyaline body is an eosinophilic globule, often surrounded by a normal parenchyma found in the liver of individuals suffering from viral hepatitis, yellow fever, or other viral syndromes. So, apart from yellow fever, this can also be seen along with hepatitis, but predominantly seen in yellow fever condition because the viral multiplication will be at the higher side, where there will be massive destruction of liver cells. It represents a hepatocyte that is undergoing apoptosis. That is the commonest and the easiest definition to represent Councilman bodies. Talking about the diagnosis, lab diagnosis, the best sample will be the blood sample. We can go for liver biopsies if we suspect a severe case. And we can go for virus isolation from the blood of post-mortem liver tissues, and the rapid diagnostic test is based on the detection of a viral genome by polymerase chain reaction, and they're not widely available right now, but we are dependent on detection of IgM antibodies by ELISA. We'll go for serological examination, where we can choose between direct ELISA and indirect ELISA. Direct ELISA is something which will identify the antigen, and indirect ELISA will identify antibodies. So we'll always go for a paired serum examination, and if there will be definitely an increase in antibody levels in serum sample, and we'll track down IgM antibodies. If you identify IgM antibodies, that means an immediate or acute infection, and if there is a IgG antibody, that's the latent phase of infection. And definitely in those cases where we identify IgG antibodies, we should go for liver biopsy examination to track down these Councilman bodies, right? So, talking about the prophylaxis, the best general prophylaxis measure will be the control of vectors, right? And that is the easiest method. Vector control Aedes aegypti control measures. That's the easiest method, which can prevent the transmission of infection. Of course, we got vaccines, different types of vaccines. French neurotropic Dakar vaccines, which is produced by infecting the virus to mouse brain and by passaging them continuously. And we also have chick embryo 17D vaccines, which is produced from ACB strains. And luckily, yellow fever is not seen in India. But vaccination is mandatory if you are traveling to those areas which are suspected to have yellow fever, or where those endemic countries. If you have to visit those countries, definitely we should take yellow fever vaccines. An Indian vaccine manufacturer in Clinical Research of India is Kasauli under WHO. We are producing these kind of vaccines, but it is not required to a larger scale because we have less prevalences of yellow fever in Indian subcontinent. All right, so this is the most important and the most dangerous virus among the arthropod family, I should say. They are dengue virus, right? So dengue virus can cause serious complications in anybody, no matter whether the person is having a strong immune system or weak immune system, and the clinical presentation varies from mild fever to severe hemorrhages and multi-system failure with a constant and rapid progression to hyperactive immune responses. So it is prevalent in tropics and subtropics. Unfortunately, it is the commonest arboviral disease present in India also. And it's dengue stands for sudden seizures by a demon. That the word dengue came from a Latin word which means sudden seizure by a demon. So they believe that it's purely because of some activities of some demons, and that is causing all the complications. Now, so it is also known as break-borne fever. The person will have severe arthralgia, severe muscle pains, and person may even feel that his or her bones are getting damaged or getting broken. So in India, it was first isolated in 1945 in Calcutta, and now it is reported in all states, right? So it is commonly caused by the transmission, or the transmission usually happens by the vector Aedes aegypticus and Aedes albopicus, and these are the two common Aedes members vectors which can cause the transmission of infection. And if we see the serotypes of dengue virus, we have identified 5 serotypes of dengue fever which are causing clinical conditions in human body, and we named them as dengue 1 to dengue 5, DEN1, DEN2, DEN3, 4 and 5. So DEN stands for dengue virus. All right. So yeah, this is how we have classified them into almost 5 serotypes: DEN, D2, 3 and 4. 5 was there, and recently we identified that 5 is not causing that much infection. So right now we will be focusing mainly on these 4 different types, and they have the shortest incubation period starting from 3 days up to 14 days. And there will be viremia, severe, mild to severe viremia, followed by clinical presentation. Now, talking about the agent or the vector, Aedes aegypti is a nervous feeder, and it bites repeatedly to one person to complete the blood meal. So there's a high chance of getting the infection not by a single bite, by repeated bites from this vector. Aedes become infective only when it feeds on viremic patients. So definitely the transmission starts from a viremic patient. And the reservoir host is usually man, and even Aedes act as the reservoir host, principal reservoir host. And if you see the incubation period, 3 to 14 days is the intrinsic incubation period that happens in human body. The extrinsic incubation period, that is the incubation period in mosquitoes, is 8 to 10 days. Right. So talking about the clinical manifestations or clinical features of dengue viral infection, it's the most common cause of epidemic encephalitis. So that's a serious case about dengue. It can develop into serious encephalitis kind of condition. So there will be subclinical infection. There will be an actual clinical course. So in subclinical condition, that is the earliest case where the person will not show any specific symptoms. But in the clinical phase or clinical course, there will be specific symptoms, which includes the prodromal phase with febrile illness. There will be it will be starting with the normal fever condition, and there will be acute encephalitis condition, which includes convulsions, behavioral changes, meningeal signs, and even paralysis. And in all this, in both the stages, there will be severe back pain, muscle aches, and joint pain. Right, and the late stage of the sequelae, this includes there will be recurrent infection, or the patient may become or may be recovered completely. So two things can happen in the late phase of this infection. The person can get recurrent infection, or he or she will be completely free from this condition. Now, the symptoms of dengue fever ranges from febrile condition to itching, seizures, pleural effusions, hypotension, vomiting, rashes we can make out from this slide. Talking about the pathogenesis of dengue viral infection, primary dengue infection occurs when a person infected with dengue for the first time. That's the earliest case. And secondary infection usually occurs. That's a severe form of illness due to the infection with another serotype, which is different from the first serotype, causing the primary infection. So secondary phase is really, really dangerous. Like I said, there are 5 different serotypes of dengue are there. 4 are highly prevalent in Indian subcontinent. So the secondary dengue infection usually becomes highly severe, or even this hyperemia with the severe rashes formation, hemorrhagic condition, and all those things can happen in the secondary case when there is 2 different serotypes causes infections together in a human body. Now, more about clinical presentation. Right. So more about the clinical manifestations. Clinical manifestations are generally classified into 3 different stages: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome (DSS). So dengue fever is the earliest phase. There will be abrupt onset of a high fever with the break-bone conditions, and usually there will be maculopapular rashes over the chest and the upper limbs, and with severe frontal headache. That's the earliest case of dengue fever. But once it develops into dengue hemorrhagic fever (DHF), that is characterized by high grade and continuous fever with severe swelling at the liver region, hepatomegaly, and the person will also experience thrombocytopenia with raised hematocrit, and there will be evidences of hemorrhages. So dengue hemorrhagic fever, or DHF, is a potentially deadly complication of febrile conditions along with the severe hemorrhages. It usually affects children below 10 years of age. It can also affect people who are above 65 years of age. And it starts abruptly with high continuous fever, and the temperature will be around 41 degrees Celsius, and they'll be bleeding with easy bruising, petechial rashes, petechial lesions. There'll be bleeding gums and epistaxis, and these are common features associated with dengue hemorrhagic fever. In moderate dengue hemorrhagic fever subsides usually. In severe cases, the patient's condition deteriorates within 2 to 7 days, and the person will lead to a condition called dengue shock syndrome, or DSS. That's ultimate condition where there is a rapid or weak pulse characterized by low blood pressure and even restlessness, and the person will have altered sensorium and other conditions. Sudden collapse and cold, clammy extremities, weak, thready pulse, blueness around the mouth, and temperature drops, circulatory failures, state of shock, and death usually happens within 12 to 24 hours. This is the third and final stage of dengue infection, severe dengue infection, dengue shock syndrome, and this usually happens when there is 2 different serotypes of dengue virus comes together, causing clinical presentation. And this has got a high mortality rate from 6% to 30%, and most death occurs especially in children. And if it affects infants less than 1 year old are especially at the high rate of risk of infection. Right, these are there will be petechial rashes, conjunctival injections, not injection, it's infection, and dengue hemorrhagic syndromes and rashes of dengue. These are the common clinical presentations associated with the dengue viral infections. Talking about the lab diagnosis, the easiest and the most prominent sample will be blood sample or serum sample. Of course, we can take CSF sample if you suspect a central nervous system complication, and the principal method is still being the serology. Of course, we can go for isolation, but that's a difficult task, and the easiest method will be going for a serological examination, where we can choose antigen detection or antibody detection. In case of antigen detection, we can take NS1 antigen detection. So NS1 antigen becomes detectable from day 1 of fever and remains positive up to 18 days. And the disappearance of this NS1 antigen will be marked by the appearance of antibody. There is chances of formation of IgM antibodies or IgG antibodies. So if there is a presence of IgM antibody, that's an early stage of infection, and if there is IgG antibody, that shows latency of infection. And cross reactivity is seen with other flavivirus. So people who have a dengue virus infection can also show yellow fever conditions or even Casnur forest disease, and at that stage the condition become really worse, and we have to take extreme care to track or bring the life of the person back to normal. And of course, we can go for virus isolation from these samples, and virus isolation is usually done by inoculating the virus or the sample into mosquito cell lines, or even mouse cell lines can be used, but that's a long process, and we don't have any specific cytopathic effects shown by this virus. The only option will be looking the sample or looking the culture plate under the immunofluorescence or fluorescent microscopy or electron microscopy to confirm that. And talking about the treatment option, there's no specific treatment options are available to complete or to contain this condition. The best possible options include replacement of plasma losses and correction of erythrocyte disturbances. We have to go for blood transfusion if we suspect severe anemia. We should also think about platelet transfusion if it is required. And prevention, unfortunately, there's no specific vaccines available. The best and the easiest and the specific prophylactic measures will be purely based on the control of vectors or control of those agents which are transmitting the infection from the patient to another healthy individual. Alright, so let's learn something about a few flaviviral infection which is transmitted by ticks. So tick transmitted flavivirus are many, but the commonest and the most significant in Indian subcontinent is of course this one, Castor forest disease or KFD, which cause severe hemorrhagic fever in affected individual. So Castor forest disease or KFD is identified from the monkeys of Castor forest in Shimoga, Karnataka. That's why the term KFD. So it can cause severe hemorrhagic disease, and the vectors are usually ticks, hard ticks, and the reservoirs are forest birds. And the hosts are usually monkeys, rodents, and squirrels, including human beings. So it can be transmitted to human body also. People who are living in close proximity with these forest area are high risk in getting this Castor forest disease. And monkeys will act as amplifier hosts and reported from Shimoga, Kutch, and even Saurashtra. Right, so that's a specialty of Castor forest disease. And talking about the clinical manifestation, the incubation period is 3 to 8 days, within the after the bite of infected ticks. Right, in human body it usually enters through the bite of infected ticks, and the first stage of infection will be a hemorrhagic fever with headache and conjunctivitis. There will be acute fever with malaise and frontal headaches, followed by hemorrhagic symptoms such as bleeding from the nasal cavity, gums, throat, as well as gastrointestinal bleeding. Right, so the second stage is meningoencephalitis. Definitely this is something which can lead to encephalitis, but this is exclusively transmitted by the ticks. That's a specialty of Castor forest disease. Talking about the lab diagnosis, the best sample will be blood sample or serum sample, and within 10 days of infection we can take the sample and we can identify the presence of antibodies in the patient serum sample. I will look for the presence of IgM antibodies. And we can also go for virus isolation within 10 days by transferring the sample to suckling mouse brain Viro cell lines or BHK21 cell lines. And these are a long, tedious process, so we won't usually do that. We definitely do something like serological examination where we can track down the antigens or antibodies. Since it is a serious intracytoplasmic pathogen, we'll definitely look for the presence of antibodies. Now, talking about the prophylactic measures, there are killed KFD vaccines are available, which is usually produced by interacting this virus with the formalin. We use formalin inactivated chick embryo vaccines are usually taken or given to the patient, and 2 doses of KFD vaccines are required at an interval of 2 months time, followed by the booster dose 6 to 9 months, and then after every 5 years. And this is something which is prescribed to those people who are living in close proximity with a forest where there is a high prevalence of Castor forest disease. And the general prophylaxis definitely is based on eradicating any vectors like ticks. These vector control will be beneficial to prevent any kind of epidemics, pandemics kind of conditions.